I can read it as we're going through. So, welcome back. I don't know if any of you were in the first session or the perimenopause one or saw any of that, but that one we were really talking about how do we identify a woman coming into our office who is in perimenopause? What do we do? What do we not do? What does it look like? Now, what we want to do this course is really dive a little deeper into specific what we're going to call phenotypes as we're going through. So women who are high impact, they've got high demands on themselves, and why they have the struggles that they have that may be different from a lot of other women going through perimenopause. Before we get into all of that, I have a little short poll, and I want to ask, where's the friction? When you have that perimenopause woman coming into your office, what are the issues that you might have? And so Katya is going to bring up our first poll, actually our first and only poll, if we can do that. Do I need to stop sharing? Maybe I do.
Let me launch it. Here we go.
There we go.
Can everyone see it?
Yes, thank
you. Okay. Okay, so this is the woman coming into your office. This is a high-powered woman, whatever it might be. What are the issues that you might find most challenging if she's in perimenopause? So is it explaining why labs look normal, deciding what to address first, managing patient urgency and expectations because they all want it done yesterday, right? Avoiding overtreatment, right? And or all of the above. It could be all of the above.
So I had 3 patients today ask me, women, very strong women, beautiful women, why do my labs look normal?
Yes.
I mean, all of these are great points, but it's like, Robert, these labs are normal. I'm like, yes, but that's not the whole story.
Exactly. Okay, excellent. So we got one for explaining why they look normal and deciding what to answer for, what to address first. Perfect. All right. So let's end that. I will share again and we will go on. So now we know where the friction is for you all. And let me close that out so I'm not looking at it. So that's our paradox. We are here, we're providers, we're into BHRT, but we do have this issue. So on the left, the input, the people coming into us and sitting across from us, what we're hearing from them, I'm doing everything right. I'm eating right. I'm working out. I'm on the right supplements. I'm taking care of my hydration. I'm doing all of these things. And like you said, my labs are normal. So of course, when when the traditional doc sees normal labs, what do? You look at that little pat on the back and a see you next year, right? Everything's fine. But the problem is the reality. The reason they're coming to see us is that their symptoms are getting worse. They don't feel good. They're gaining weight that they never gained before, doing the same thing they used to do. They're tired. They're anxious, which is like, how am I tired and anxious at the same time? Brain fog and insomnia. And they're frustrated. They are frustrated because they say, just like this is, I'm doing everything right. Why do I feel so wrong? Okay, that's what we hear over and over and over again. So briefly, I just wanted to introduce myself. If you don't know me at all, I'm Dr. Susan Lavelle. I used to be a ballerina. So before I went into medicine, for almost 17 years total, I was a professional dancer, traveled around the world, loved it. But the thing with that is it's a lot of, well, first of all, you don't take care of yourself because you have to be rail thin. You are performing because this show must go on no matter what, right? And you're not eating right. So that was years and years and years of abusing my body mentally, physically, and emotionally. There was a lot going on there and emotionally as well. I took that with me when I went into medicine. And I went into plastic surgery for the next 22 years. Don't add those numbers up. It's not that important. Anyway, I loved plastic surgery because I was all about transformation. Someone would come in one way, you would do something and they would go out. It's the one reason I didn't go into internal medicine, not so much internal medicine, but just traditional medicine, where someone would come in, they would have a problem, say it's diabetes or high blood pressure, you would give them a medicine, they'd go back out and they'd come back the next month the same way, because there wasn't anything there to help them transform. Anyway, I took all of that, but took that show must go on mentality with me into plastic surgery, which was wonderful as far as the patients were concerned, not so great for me. So I was that high demand woman, in the operating room, 6, 8 hours a day, having kids, raising kids, and trying to be soccer mom at the same time I'm up all night with patients and everything. And eventually I broke down 3 times in an intensive care unit in the space of a year. And that third time was when I said, okay, this doesn't work. I've got to do something different. And the way I healed was through lifestyle health, when we started looking at why things break down versus just they broke down, let me fix it somehow. Okay. So that's what we're going to be thinking about today. If you have someone that or that you're working with, keep them in mind as we're going through these things. Who is that high demand woman? What are her specific needs and how do we start addressing them? So especially when we get to perimenopause, and this is really what this is all about. So the old model, really, and a lot of us still work this way. I tend to default that way. Someone comes in, they come in with their labs, they come in and you'll see they've got an estrogen deficiency. What do you want to do initially? First thing, let's replace it. Let's just give them back some estrogen. They need it. Let's just replace it, which, eventually we may end up doing. We think of that hormone decline as, 20 and then 30, and each year it's getting lower and lower. Each year it's just kind of going down in a very straight decline. Well, if you've been in hormones for any period of time, that's not the case. It fluctuates a lot, especially in perimenopause. So it's really that up and down kind of stuff. And the hormones are like the number one thing. So we see something's wrong with hormones, we just give them the hormones and everything's fine. Sometimes that works. A lot of times that works. The problem is there a better way? And we're going to be talking about how that might be. So now that we understand that there is that instability, it's the up and down. We talked about that in the first class. And the system doesn't have the capacity anymore to compensate for stress. And that's why we start seeing a lot of the issues that we do when women are going through perimenopause. It's not just the stress, it's not just the hormones, it's the combination of the two at the same time. We got these erratic highs and lows, right? And then we want to start looking at the systems, okay, instead of just a particular hormone. So here's that load.
That was a great job at that neuroendocrine volatility. Fabulous. Mm-hmm.
Yeah, exactly. It's volatile. It goes up and down. A lot of us think, okay, it's just down and let's just give it. But sometimes, especially in perimenopause, if you give estrogen, you're going to shoot them up in the wrong direction, like too high. So you really got to figure out what's going on and why. So here now we've got that volatility, right? It's going up and down. The ovaries are like doing their thing. But we add that to our external load of that chronic demand. So these women who have that high demand life, whether they're executives, we're going to be talking about 3 specific phenotypes: executives, healthcare workers, and also athletes, elite athletes, not the ones who are like after, weekend warriors. So you put those 2 things together, and where they used to be able to thrive, now they fail. Everything neuro-metabolic chaos. And so here's the thing. It's not one or the other, because throughout life, they've had both, but they've never had them both together like this. And that's why that buffer that's now gone is the problem. So, we look at this, the last 20 years, when I had my issues, and now that I'm looking back on it, I was going through perimenopause when it all hit, right? But I didn't know that back then. I was a plastic surgeon back then. I just knew that I was having issues, right? High demand, they've got these stresses, they've got the estrogen buffer, for the last 20 years when they are premenopausal, and they can adapt. So they did great. There was really no problem. Well, for the most part, they did great. Their new reality now, what makes it so hard, same demand, but now the buffer's gone. They don't have the hormones that were protecting them in the levels that they did. Estrogen, progesterone, testosterone, DHEA, these levels are just kind of fluctuating all over the place. And this is why they crash. So just estrogen alone, and we talked about a lot of the other hormones last time, but let's just talk about estrogen alone. What are the systems that it's actually protecting us from? Well, of course, number one, the HPA axis, okay? All of the effects of cortisol on the brain, on cortisol on our body, on our muscles, on our heart, everything. So that buffer is starting to go, okay? Neuroinflammation. So where they didn't used to be inflamed before, now they are, okay? Insulin sensitivity. Again, they were never even close to being pre-diabetic. They could eat whatever they wanted, not a problem. Now, all of a sudden, they eat an extra cookie, their blood sugar spikes or something else is going on because they don't have that same buffer that they used to. Metabolic flexibility, and we'll talk about how we used to be able to fuel switch before, and why a lot of fasting no longer works, or it doesn't work the way it used to. Neurotransmitters, we're going to be talking about these. And then finally, sleep, okay? So the whole thing is, we know the hypothalamus is that command center, right? The HPA axis. So we know we've been over here, with problems with that chronic stress. It's kind of is suppressing the HPG axis. Our receptors, adrenal output is also messed up. But now, like I said, we're adding not only the stress, but we're adding the issues with the HPG axis. So those signals are now that we know now are erratic. The surges of FSH and LH are unpredictable. That's the whole thing of perimenopause. And then finally, everything is inconsistent. So all of that, as we just mentioned, ends up in that systemic breakdown. So now they're not sleeping. Their appetite's out of control. That's where the flashes and the hot flashes come from. And you'll often see a lot more immune dysregulation. So again, even though about 80% of autoimmune issues are in women, we'll start to see more of them developing in this same perimenopausal stage. And this is one of the reasons why. So remember this, the hypothalamus doesn't prioritize performance. It prioritizes survival, okay? And survival always wins in stress. So let's talk about specifically about the neurotransmitters might be going on, because what happens when they come into your office? They tell you, I went to my doc, went to my PCP, and I told them, I was either depressed or anxious or couldn't sleep. And what is the number one thing that they come away with? They're going to get a prescription usually. What's that prescription for? Since we're here. And I'm going to say,
depression, anxiety, SSRI.
Exactly. Even in plastics, 70%, because I counted it once. At one point I was like, this is crazy that so many women are coming into my office on antidepressants. It was 70% of women were being placed on SSRIs or antidepressants. Okay. Where, we're going to go through it. That's not the problem. Are they? They may be depressed. They may be anxious. They may not be sleeping well, but an antidepressant is not the answer. Okay. So what are the 4 neurotransmitters that are going offline? Okay. Well, first is serotonin. And well, let me ask you, how many of you, did I have my, oh, you know what? I forgot to put my chat back up again. How many of you, have done any functional medicine training or any type of other than traditional hormones? Well, actually, if you're doing BHRT, you're already doing other than traditional medicine, because traditional is not really the HRT, BHRT advocate. So Serotonin is one of those neurotransmitters made in the gut. 70% estimated of what we make is made in the gut. It's all about our contentment, our mood. Of course, it is our gut health as well, but for here, we're talking about this. And what happens when those levels start to get out of control? Well, they come in depressed, anxious, irritable, and they want carbs. I hear that all the time. It's 3, 4 o'clock in the afternoon. I got to get my coffee and a cookie. You've got to get something to give you that boost in the afternoon. And that's because estrogen modulates all of that synthesis and the receptor density. Okay. So, what about dopamine? That's your motivation and reward. What does that look like? Life is flat, it's gray. They don't have any drive anymore. They can't concentrate anymore. And again, estrogen is there modulating that reward system. What about GABA? Okay. GABA is all about calm. So what happens when that starts getting messed up? So now it's not so much the estrogen, but it's progesterone, right? Now they still have that anxiety and insomnia. That's why a lot of times, if you have someone coming in, you worked on everything else. We know we got to do the lifestyle first. We know if they've got a TV blasting in their room and looking at the computer, right before they go to bed and all of that, it's going to be really hard, even for progesterone, even if they're low in progesterone, for that to work. So we want to make sure we're taking care of all of that lifestyle stuff first, but then if they are still low in progesterone, that's why it has a wonderful effect. It's got that GABA effect on their brain. And then finally, the opposite, the glutamate, okay? So if it's too high, you're going to start seeing that fog, the sensory sensitivity and agitation, that anxiety again. So all of these things are going on with these neurotransmitters. So all of these can be related very clearly to their hormones. And if we fix the lifestyle, fix the hormones, then guess what? They don't need the antidepressant. And so many of the people that we take care of come off of them, are able to come off of them when you actually figure out what the real cause of what's going on. So she's describing her neurochemistry. Okay. It's not that she's nuts. And we hear that all the time. Okay. Here's another one. And we're going to be seeing more and more and more of this sleep insulin weight cascade. So now we've got the estrogen going up and down. We know that they're hot. How many times, if you or your wife or your loved one have gone through perimenopause, how many times they wake up in the middle of the night, if they haven't, gotten things straight before then, either throwing the covers off or waking up with hot sweats or cold sweats, whatever they might be, you're waking up. So that's messing up. You're not only you hot or cold, but now you can't sleep. Well, if you can't sleep, cortisol levels go up, right? Ghrelin goes up, with that hormone that actually makes them more hungry, and their leptin goes down. So now they've got, the triple whammy. So now they're just hungry all the time. Goes into insulin resistance, and they're going to start storing fat instead of getting rid of it. And then they're gaining that weight. Okay. So then it starts that whole thing when they're starting to make more estrogen and getting back into that. And it's just this vicious cycle. And they'll say, I'm eating less, but I'm gaining more. Okay. Doing all the good stuff, but still having issues. So then this is another one we're seeing, is that the body can't adapt anymore to the fuel demands. So we're seeing here in an athlete, but in pre-perimenopause, does that make sense? So before they go into perimenopause, their body is able to adapt. When I was a dancer, I could not eat all day and still work at night, and it, be in a performance at night, and it wasn't a big deal, However, so what was happening is if I had glucose, I was able to have that fat burning. If I fasted, I turned on that activation. If I exercised, I adapted and I got stronger. And if I did, if I stopped eating for a day or two, pounds just dropped right off, right? Because that's the way it was. And your lean body mass stayed stable. Well, when you go into perimenopause, what's starting to happen? All of that, all of that fuel switching changes. Your glucose now is getting stored. Okay. It's no longer being used efficiently and effectively. A lot of times now, if they're fasting, they're breaking down muscle and breaking it down fast. And we're starting to see this is a little bit of an aside, but we're starting to see that also with the GLP-1s. Where if we're not careful and we don't really let people know, you can't just not eat. You've got to, if you're going to drop what you're eating, you've got to make sure that your protein intake stays high. Otherwise, because otherwise, the muscle's going to break down. Exercise will start leading to inflammation. And that's another big one. Something that never used to happen, with especially with elite athletes, where they could train hard for long periods of time. Now, when they start training hard, they start getting inflamed. Their body starts getting inflamed. We'll go more into detail with that. And when they go into a caloric deficit, their whole metabolism slows down. And we see that a lot, on what was that show, The Greatest Loser or something like that. They would lose all this weight and be wonderful for them, right? Until they got off the show and then you checked, and over 90% of them, which is kind of scary, over 90% of them gained back at least as much as they were before, if not more. Why? Because when you do that really hard caloric deficit with work on top of it, you just slow all the metabolism down. So now, rather than lean body mass being stable, now they're gaining fat mass every year and their lean mass is decreasing. And as we well know, less lean mass, less metabolic flexibility. And it's just, again, this vicious cycle that they go through. So they're training harder, but they're getting softer. Okay. So the key point here is that strategies that used to work at 35 are accelerating decline at 47. And if you remember from first class, at 35, that's about when progesterone starts to decline. And how interesting. Okay. Now let's look at the whole driver, because this is where I want us to start changing our thought patterns and how we're thinking about things. So rather than jumping immediately into optimizing, let's start thinking about restoring first. And a lot of times you may have to do them together, because as we were talking about before, these are women who are coming into us and saying, look, I've been working at this for, I don't know how long. People are telling me it's all in my mind. I want it fixed and I want it fixed yesterday. Okay. So we've got to figure out how we actually do that. So we want to look first at those primary drivers. What are we going to address first? Because if we don't address this side over here, we're going to get to in a second, will work, but it may not be as stable and it may take longer. So first, we want to make sure we're taking care of whatever HPA axis dysregulation there is. And a lot of times we know if they are stressed for long periods of time, they're either going to have a really wild glucose curve. If it's not really high in the morning, which I'm going to admit, mine tends to be, if I don't watch out, that's where I kind of tend to go. But if you do that for long periods of time, eventually it starts to just kind of flatten out, because eventually the body's like, I'm just done. And whatever you want to call it, adrenal fatigue, adrenal dysregulation, whatever you might want to call it. Circadian disruption. How many times will they come in? And I pretty much always, if they're coming in, I ask them, how do you sleep? Do you, and make sure that you're being very specific about what their sleep issue is. If they're telling you that they're not sleeping for at least 7 hours a night, and 7 to 9, as we know, is the best. If they're telling you it's less, then you want to ask them, first of all, when are you going to sleep? Is it that you have difficulty going to sleep? Is it that you go to sleep no problem, but then you wake up at 2 to 3 o'clock in the morning? And we know the reasons for that at this point. Or is it that you can sleep through the entire night, but you feel exhausted still in the morning? So those are three different things going on. So when someone's saying to you, I don't sleep well, you have to really dig down deep into it and figure out why they're not sleeping well, or what it is when they say, I'm not sleeping well, what does that mean? Systemic inflammation, we talked about that. Um, you lots of work, if they're working, they're more likely to have more inflammation. We're going to go into that in just a second. Insulin resistance, and then the gut dysfunction. That's a whole nother topic altogether. And we're going to go into a bit more of that next in our next talk, because we're going into looking at the gut and the beta glucuronidase and all of those things on our next talk. So instead of just asking, okay, what hormone's missing? Let's just give it to them and then they're out the door. Let's start looking about fixing these first. And like I said, sometimes you've got to do them simultaneously or as close to simultaneously as possible, but you don't want to ignore these or just say, just give the hormones are going to fix everything. Okay. And so instead, we want to look at what is that smoke? What's the other problem? Their hormone output, obviously. Thyroid optimization. A lot of times we tend to forget that. The thyroid is a huge, hugely important hormone, along with the adrenal, their neurotransmitter levels, their libido and mood, and of course their energy and motivation. So these are, is especially if you only have but so much time and they have but so much patience because they've gone through so much before, you may have to do them almost simultaneously. But as I was saying, you don't want to just say, okay, this number is wrong, let me fix that number. Okay. So let's go into the three phenotypes, one physiology. Okay. The first are the executives. And when you look at these things, you'll see that, of course, things can flip through all. So a healthcare provider can have decision fatigue and sleep truncation, and same thing, they can flip back and forth, but I've separated them out with the things that are most descriptive for each one. So the executive, they're the ones with that brain load. Okay. So decision fatigue. I've spoken to so many executives where they're just saying, if I have to make one more decision, I'm just going to rip my hair out, and we know that is an issue. Decision fatigue is real. Okay. Sleep truncation. I'll sleep when I'm dead mentality. Sleep is for the weak, rest is for the weak. And then the cortisol flattening. Remember, I said initially it can be kind of like really bumped up in the morning, but then if you continue and you don't care for anything, eventually it stops being as responsive. So that they're always on. As a dancer, remember I said you were always on when you were on stage, and that is masked by high function. So they keep going, and they look like they are, they just keep functioning no matter what. The elite athletes, on the other hand, have a physical load. Of course, do they have cognitive and emotional? Yes, but their main thing is the physical load. Again, under recovery, because they have to be out on the field, their training intensity sometimes goes beyond their capacity to repair. And I forget the team. Was it the Broncos? Someone who was the football team was just playing, and their quarterback played the entire game, got to the end of the game, and found out he had broken a bone. So it's like there's so much. An elite athlete is so much into the game, so much into production and the result, that a lot of times they neglect their body and their care until it's too late. Red S, so a relative energy deficiency in sports. And so this is when the calories are not matching the output. Big in dancing, okay, because you had to be rail thin. You were not eating for the most part, for whenever you were performing. So the calories didn't match. And then the last is that chronic inflammation. So you're inflamed, you have an injury, you don't want to wait until it's completely healed. So you get back out on the court or the field or whatever it might be. And how are they masking their issues? Discipline. Okay. You're going to get out, you're going to run no matter what. You're going to get out, you're going to lift no matter what. And that's a problem. And then finally, healthcare providers. Woo, yeah. So we went into the field that we're in because we care about others. Okay. And a lot of times that, we're talking about caregiving fatigue and self-neglect. A lot of times we're up at night, especially in training, we're up at night taking care of people. And even afterwards, when we're building a practice until we get to the point where we have enough help to make it more sustainable. So for quite a few years, we are pushing ourselves 24/7. That was me when I moved, I had moved to a small town in Northeast North Carolina. I think actually, we have a lot of people from North Carolina. So I was in Elizabeth City, and there was no other plastic surgeon for an hour in any direction. So that meant, like I said, I did my surgeries during the day. So my patients came home, was the soccer mom. And then 2, 3 o'clock in the morning, when some child had what we call a kitty lack, they would fall off a table and get a cut on their face. Who are they calling? They're calling the plastic surgeon. So now I'm working, 24/7 without really taking care of myself. Hypervigilance. We are always thinking, and it's a little bit doomsday-y, but we do it anyway. What could go wrong? Because we want to know, we want to make sure we're not leaving anything out. That's one of the things that most of us are most concerned about. Did I miss something with this person, or could I have missed something? Could I have done something better? So that hypervigilance, that's always there. And whether or not you do shift work, that would be just another thing on top of it. Okay. So let's go into the executive. What does it specifically look like for them? How do they get dysregulated? Well, the first one I talked about was that decision fatigue. So that's that prefrontal cortex, one after one after one, decision after decision after decision. You get to the point where I just can't do anymore. Okay. 5 to 6 hours normalized as enough. I function fine on less sleep. And I often ask, how many hours of sleep is good? What is the best sleep? And people will consistently say, oh yeah, 7 to 9 hours. They got that down pat. And then you ask them, well, how much sleep do you actually get? And then that's when you get the 4, the 5, and sometimes the 6s. Okay, that's consistent when you're speaking to this particular group. So you can't just say, do you know how much sleep you should be getting, but actually how much sleep. And like I said before, what does it mean when you're not sleeping well? That cortisol flattening that we were talking about, tired all day, wired at night. Okay. And then finally, this is what it looks like. The labs look normal until they're bad, till they're really bad. And we know why that happens. There's a lot of dis-ease. It's no longer dis-ease, it's disease in our normal values. So we want optimal. And that's why they're coming into your office and telling you something's wrong, but nobody can tell me what it is. Okay. So the insight here, high performers compensate until they can't. That was me. That's pretty much anybody who's coming to you who is just, well, I'm going to say busted, and it's because they've been able to compensate until the point that they just can't anymore. All right. Elite athletes, the more is better trap. Okay. So they've got these 4 things going on. And a lot of them will say rest is for the weak. No pain, no gain. That isn't what you hear over and over and over again from these elite athletes. They are going no matter what. It doesn't matter, until they can't get up any longer. So like I had mentioned before, the red S. So if their energy, so if they're doing less than 30 kilocalories per kilogram of fat-free mass, you're going to start triggering the HBG suppression. Okay. Injury risk, and look at that risk, 2 to 4 times higher because when they start going through perimenopause, because collagen is there to strengthen, estrogen is there to strengthen collagen and bones and ligaments. Okay, so if you don't have that, testosterone also, we'll talk more about testosterone in another session. But then we start to see stress fractures and the tendons start ripping. Why do soccer players have so many ACL tears? This is why, okay, as they start to get older. That chronic inflammation we just talked about, and then they're not adapting as well as they used to. So they are training harder, but they're doing worse. They get to that point where they plateau, and then the plateau starts going down in the opposite direction. All right. And then finally, the healthcare workers. So now they've got no off switch, that sort of thing. So they've got the circadian issue. If they are shift works, then they're totally working against the biological clock for the most part, unless they're in that 7 to 7 shift, 7 a.m. to 7 p.m. They are definitely working against the normal circadian rhythm, and they're suppressing their melatonin if they're working at night. But also, think about it. If you were going through training, what did you do? You got called in the middle of the night, especially if you were in a smaller town, or where you didn't have as much support with, say, residents or something. Then you, as the attending, are getting up in the middle of the night to take care of people. So that's really messing with that circadian rhythm. Psychosocial. How many of us, I think we all probably do, have that patient that we remember, that first patient that we had who died, and it just ripped our heart out because we couldn't do anything about it. Okay. But we learn to put that face on. We learn not to show our reactions. And that hurts us too. Okay. And we may never process them. Hopefully we do, but sometimes we don't. Okay. Immunological. As I was saying before, we tend to not heal as well. We tend to start seeing more and more of the autoimmune issues. Number one, because we're just exposed to so much stuff, just by nature of seeing patients and clients. But that, as we mentioned, also the exposure and the stress will lead to that inflammation, which then leads to all of the cytokine cascades and more illness and other issues. Okay. And then finally, that whole mind-body connection. We know that there is one, but sometimes we forget. And so when we are exhausted here, our body also gets exhausted. And that's where we can have these pictures that look like this. Happens a lot with shift working nurses, but anyone who's got those hours that are not consistent, and usually are the ones that are later during the evening. Okay. So we've gone through many years where we could just go through and push. And as I mentioned before, last 20 years, no problem. That discipline was fine, but we had the estrogen, progesterone, and the testosterone buffers. And so we were okay. We could work harder. We could push through. And it worked, But now we see that our discipline, we don't have a buffer anymore. So that same work harder, push through, rest later means we break down. Okay. And so we've got to be able to reframe it for them. And this is an important thing. We've got to be able to show them that it's not their discipline. Okay. And because when they can realize that, then they're going to be a little more likely to say, okay, I need to step back. That's one of the hardest things for anyone to do. Your physiology can no longer afford your discipline. One of the things when I first made that switch over, and I wasn't willing to tell people that they needed to stop, if it was their job or their profession. I was working with a musician for a year. I'm going to admit it. I was working with them for a year. But this musician would go on tour, and of course, when do they perform? They perform at night. So every time he went on tour, everything went haywire. And so we would fix things and tweak when it came back, and they would be fine, and then go off on tour again, and everything fell apart. And it wasn't until I finally made the thing. It's like either you have to accept that you're older now and you can't tour like this anymore, or you have to accept that you are going to have these fluctuations in and out of health. It's a tough decision, but sometimes we have to make them understand, or help them to, not make them, you can't make anyone do anything, but help them to understand what it is that's pushing their issues. Okay. And so what do we tend to do? The first thing, we chase lab values. Okay. How many of you have heard this one? My doc told me my TSH was normal, so my thyroid is fine. Well, first of all, it makes me want to just rip my hair out. Well, what little bit I've got, but because the TSH alone, if you've been in this field for any amount of time, you realize that is not nearly enough to say whether or not your thyroid is healthy. Okay, you need more than that if you're going to look at it that way. But even if it was, even if you got all of them and they were all within that normal range, well, what if they're all on the low end? Or what if they're all on the high end? For that particular person, for their unique physiology, what does that mean? Okay, they're a snapshot. If we're looking at their estrogen, especially during perimenopause, you can look on it one day and it may be high. You look another day, it can be low. You have to understand that labs are just that snapshot. Okay, kitchen sink protocols, because we want to fix everything all at once, right? And so, how many times do you have someone coming into your office or your center who's on a bag full of supplements? And so that's another thing that happens. And some of it may be one provider who just gave them everything all at once, or, and what I see even more frequently, is they'll be put on a supplement by one provider, but then they go to another one. They don't necessarily tell the second provider what they're taking. And so now the second provider is adding something, and it's just kind of this cumulative supplement load that no one's really checking or going over. So, but the problem with that is the more supplements, the more you're overwhelming that system that's already overwhelmed. And so just like a little caveat is, if you can keep it to 5 or less, if you have to, this is if you have to, 5 or less to begin with, is much better than giving them everything to fix everything all at once. So prioritize, go through that list we were talking about, prioritize, and then go. And then ignoring the stress load. Okay. We cannot just give. How many times did someone come in and they say, well, my friend got testosterone and now she feels wonderful, so I need testosterone. How many times do we hear that? And so they want you to do that, right? And even if you check their labs, and even if it is abnormal, you don't want to just give it unless you know what's going on with them specifically. Is their testosterone low because they're shooting it out their body, they're using it? Is it because it's not being converted, or is being converted? You need to know what's going on before you start doing things. And so what happens when we chase lab values, follow these throw everything at it all at once protocols, or ignore their stress load, is a lot of times they're spending hundreds, if not thousands of dollars, and they don't feel better. I just admitted to you, I work with this, it was a musician, worked with him for a year before I had enough clinical maturity to put my foot down. Okay. And they don't feel better if you're not doing the right thing for them. And so the better way is to identify the primary driver, then restore that, and then start optimizing. Okay. So that pivot, from going from starting with optimization, focusing on what's missing, giving it to them right away. What can I add? Let's do something right away to restore. Figure out what is overloaded, what needs repair first. Okay. So before you add the HRT or the supplements, you want to start thinking to yourself, can this body use what I'm giving it? You know, a lot of times, as I went through training, initially going into functional and lifestyle health, there was a whole big thing about the order that you treated if someone has both adrenal and thyroid issues, which you would treat first if you couldn't possibly do them together. And a lot of times we jump right into the thyroid first. But what we see now more and more is if their adrenal's not working, you can throw a whole lot of thyroid hormone at someone and they still won't respond because their body can't utilize it well. And so you've got to really support things in the proper order for that particular person. Okay. This matrix, I'm just reminding you from the first class that we had gone through, what do these three things with estrogen and progesterone look like? So, if they're coming in with a relative excess, now we're talking about what we call estrogen dominance. They're coming in with those heavy clotting periods, okay? Breast tenderness and swelling, irritability and rage, fluid retention, and menstrual migraines. And so, if we start, and we'll talk about this in the later class, when we start replacing, we want to follow these symptoms too, okay? Because it's not just what are their numbers, but how is their unique body responding to what we're doing? So we may give them estrogen because or estradiol because their numbers were low, and we think that's going to help, but it may flip them into a picture that looks like this. Okay. Or could be a pure deficiency. So this is what we think of as classic menopause. Now they got the hot flashes and the night sweats and they're just waking up and throwing covers off and everything. Vaginal dryness is huge, huge. Okay, so if out of a lot of the questions and issues and complaints, if you can fix just that, with the right approach, you will have a patient who loves you for life. Okay, brain fog and memory, joint pain, something we don't always think about. With estrogen, low levels of estrogen, estradiol is joint pain. Same thing with testosterone. Those two are very much related to joint pain, joint health and bone health. And then finally, that depression. And then finally, low progesterone. What does that look like? Anxiety or panic, insomnia. A lot of times that 2 to 4 a.m. awakening can be almost miraculously flipped with a little bit of progesterone, okay? That premenstrual spotting, and that'll be a little caveat we'll talk about when we start talking about prescribing. Shorter cycles or really irregular cycles and much lower stress tolerance. So they're more likely to fly off the handle, okay? And just use this, think about what I want you to challenge you to do is start thinking about what's going on with them even before you get labs. Let's think about what if we were in the, we'll say the 1700s, okay? Because even the 1800s, we didn't have labs to check. We had to look at the patient and decide what was going on with the patient, okay? And so maybe we start looking at these symptoms that they're having and work with these as opposed to necessarily just jumping to work with numbers, okay? And so 3 essential questions, and we're going to go, when we break up, we're going to, and actually we may just do it all together, work them through. We're going to go through 3 cases, but as we're going through, these are the things I want you to think about first. Is the system capable of using what I'm about to give it? Number 1, okay? Number 2, what is overloaded versus what's missing, okay? Does it really need to be replaced? Or is there something that needs to be supported before we start replacing? And then 3rd, which system lost the capacity to compensate? Okay, was it the HPA axis, the gut, metabolic flexibility, whatever it might be? What is it that's needed before we can start fixing things? And you start with one. So if your answer to one is no, you got to start with restoring. Okay. If the body can't use what you're about to give it, you've got to go into that. Okay. So this is perfect timing. We're going to do those three phenotypes and go into those. Before we do though, any questions that or things that anyone has at this point before we go any further? Okay, good. So case number one, and now you should be able to, if you have, we're able to download it, you can write on it. If not, you just use a piece of paper and go. So this is the perfect patient failing. This is Maria Rodriguez. She's an executive, 47, VP of operations. So you know she is a busy woman. Okay, she's working all the time. Okay. She's got 2 children. The BMI is 24. So she's, she looks pretty normal. Okay. But what is she coming in with? She's saying, I can't think. I feel like I'm losing my edge at work. Unexplained weight gain, insomnia. She's waking up and she's irritable. She just doesn't feel like herself anymore. Okay. Her history, high performing career for 20 years. She sleeps 5 to 6 hours a night. I function fine. She's eating a strict clean diet and she's intermittent fasting because everyone says that's the best way to keep your weight down. And she takes 12 or more supplements daily. Okay. She got labs returned within normal limits. Her TSH was 2.5, estradiol 45, FSH 12. Her primary care physician offered antidepressants and sleeping pills. She didn't want them and said she felt dismissed. So she is now doubling down on exercise because she doesn't like this weight and she's fasting more, but she keeps feeling worse. Okay. So we're going to talk about which system is the primary driver. I gave you a hint. It's not her ovaries. How is her discipline, which is fasting, less sleep, working out harder, actively feeding the dysfunction? And what is the one thing she needs to stop doing before you add any treatment? So before we do that, we got those 3 questions going on, and I'm opening it up for a discussion. I want you to come on camera if you would.
So since she's high functioning, her cortisol level is extremely high, and that's driving her insomnia, which is also going to drive her hormone pathosis. So she got quite a few things there going on.
Excellent. So if she's, this is 20 years, so she probably does have that really high cortisol in the morning. But what might she also have with cortisol still? This is now 20 years. It's not 1 year or 5 years. This is 20 years of this, this high energy kind of stuff. What might also now be starting to happen?
How old is she again?
What did I say? 47?
Oh,
I need to pull this up. 47. Yes, she's 47.
Her hormones definitely into play there.
Yeah, she's starting to pull, right? Do you want me to? I can pull this slide back up again, and maybe I'll do that. This way you don't have to remember the details as we're going. There we go. Okay. So we see, oops, don't want to go to her yet. Those are her symptoms, right? So yes, I definitely think the HbA axis is the main driver with this particular woman, right? That 3 a.m. waking kind of stuff. Okay. That's because that's essentially between 2 and 4, that's when those hormones start shifting over, right? And that's why, your cortisol is starting to come up a little bit so that you can wake up in the morning. Your melatonin, if you've got enough, is starting to wind down. So you've got those 2 things crisscrossing around 2 to 4 a.m. But she may also have, remember when I said how old you were when progesterone starts going down, She's 47. It's been dropping slowly since she was 35, somewhere around there. So now she's got three hormones that are kind of not great at that time, 2 to 4 in the morning. What then? Remember what I also said. What is she doing? Is she sleeping right? Is she going to bed after wonderful sleep hygiene? What am I talking? You're supposed you guys.
Right, right. So obviously she's not getting enough sleep. So we mentioned that she's not getting enough sleep, and then she's probably overstimulated too with all the supplements too.
Exactly. Who know? Everything works against not works against each other, but it has the potential to work against each other, right? So that's another thing she's got going. The supplements. What about that fasting? What is that doing?
So that may be dropping her metabolism, her glucose. Sure.
Mm-hmm. Mm-hmm. Okay. So she's got another thing going on as well. So, and when she says clean diet, this is another thing I have learned over the years.
Yeah.
When people say I'm eating a great diet and everything, you got to ask them exactly what great means to them. I had a woman who said, I don't know why I'm not losing, because I usually give people, a meal plan if they need it, if they need some guidance. And I would give them a meal plan. I don't understand. I'm just eating chicken and vegetables every day. And I don't understand why I'm not losing weight. So what I have learned is that when that continues, the first thing to do is to ask them to send you a picture of what they are eating. Her picture was chicken nuggets. That was her
Oh. That's chicken.
Chicken is chicken, right? So you really got to ask them, what you get. And if you ask them, they may not to just send me a picture. Because a picture speaks 1,000 words, right? Yeah, so that sort of thing. So which system is the primary driver? I think we all agree the HPA axis. Okay. She's been stressed for 20 plus years. When we look at it, we can support the adrenals without even knowing what the numbers are. You know what I mean? With sleep, with stress reduction, with what they're eating, with their, that sort of thing. So we don't even have to go into the labs initially unless we do those things. Remember, we start with the lifestyle, first. If that's not doing it, then we get the testing. That's what we'll be looking at next time. Okay. Second question, how is her discipline, the fasting and the less sleep, actively feeding the dysfunction? Well, we just talked about it. She's not sleeping. What's happening to her hormones?
Definitely driving that to be out of sync.
Exactly.
Because you need the sleep in order for everything to reset. Absolutely. And the growth hormone, all of that. So
yeah, exactly. You need that. That's when your brain detoxifies. That's when your body detoxifies. And if you're, what I tell people again, if they're not convinced, whether sleep is important or not, and weight is their biggest issue or concern, it's their biggest concern, not necessarily their biggest issue. What I tell them to do is literally weigh themselves on a good night's sleep, first thing in the morning, and after staying up late or waking up. And I guarantee they will be heavier on the days that they don't sleep.
Interesting. I'm going to try that. I never thought about it.
Yes. Guarantee. And, so then they're like, so my sleep really is important, that kind of stuff.
Restorative for a reason.
Exactly. So that would be the less sleep we know, and then the fasting. So there are more and more studies coming out that are showing that fasting is not the end all and be all for women, especially going through perimenopause and going through certain parts of their cycle. So we have to be careful. It's the same thing with training. Like with the elite athletes, they have to be very careful what time during the month, if they're still menstruating, what time they're doing their heavier training, because they're more likely to tear their tendons and things during the first part of this.
And it makes sense too, because during that time that you are menstruating, your cravings go up. you know.
Yeah, yeah.
So you wanted to eat more.
Hmm.
You needed more fluids, so that makes a lot of sense.
Yeah, exactly. Exactly. And then what is the one thing she needs to stop doing before you add any treatments? And this is one that you can kind of go back and forth about what you might say, could be the crappy sleep, it could be the intermittent fasting. We also want to look at those supplements she's taking and make sure that they are all, well, first of all, no one most likely needs to take 12, especially when they're really struggling. Remember, the body, everything you put in the body is stressing the liver, which then stresses the body. So we want to
Especially
make
she's not
sure.
sorry, yeah.
Yeah,
Especially
yeah,
she's not feeling better, you
yeah,
know.
exactly.
Mhm.
So take a look at them. What are they? What can we cut out? Maybe knock them all out and then see what actually makes a difference going forward.
Mhm.
Okay. Yeah, yeah. All right. Any questions or anything else about Maria? So we have a plan for her. We're gonna tell her you gotta sleep.
Mhm. Proper diet.
Proper
And
diet.
then,
Eat.
yeah.
Yeah,
And then
yeah.
whatever she could do to decrease her stress load, selfie day or whatever, mental health
Exactly.
day, whatever she could do to decrease her stress load.
Exactly.
So a
Tell
quick
her.
question about sleep.
Mm-hmm,
So I absolutely agree. Sleep could be a problem and a culprit in this issue.
mm-hmm.
What are your best opportunities? What are your best suggestions for helping sleep?
So the first thing, I literally always start with their sleep hygiene.
Mhm.
Okay, before we do anything with what are the supplements, what do they do? Sleep hygiene. Number one, is there a TV in the bedroom? If there is, get it out. It's huge. Even if they think it's not interrupting their sleep, it does. Okay, so that's number one. Number two, is it cool enough in their room? Is it dark? A lot of people feel they have to sleep with a light on. You can't. Well, yes, you can sleep, but you don't sleep well with the light on. So those three things. Then number four, when do they come off of the screens? Again, are they working on their computer? Because this is an executive, they're working, they try to work around the clock. Are they working on their computers until they're going to bed? Are they in the bed working on their computers or their phones? Okay, taking that off. And then what are they doing to reduce their I'm not even say they're stressed at this point, but their level of anxiety or whatever they're doing right before they go to bed. So are they doing something like journaling or yoga or a warm bath or whatever it might be? What are they doing to slow things down right then and there? The other big thing is, and this is almost counterintuitive, especially to women who are trying to lose weight or are concerned about gaining weight, is that they need to make sure that they have a certain amount of protein on board when they're going to sleep. And the reason for that is a lot of times because remember, now they've got this whole insulin insensitivity thing. So now their glucose is bumping up and down during the night. So if they have protein, it tends to stay more stable during the night. If their glucose is dropping because they had a carby kind of dinner and it went up when they went to sleep, but then it plummets, a lot of times 2 3 again o'clock in the morning is when they start the body's going to wake it up. Remember what I said, the body's going to prioritize its survival and it knows if it's starving it needs to wake you up so you go get something to eat. So that's another big one. And if they don't believe that one, something that another little caveat that I love, everyone that you're managing should, especially if they're struggling with weight, but I think everyone should wear a continuous glucose monitor for a couple of weeks and just follow what it does for them. What's triggering their particular glucose to go up and down. And a story that I put one on my daughter used to wake up with headaches all the time, and we didn't know why. Well, guess whose glucose was 47 in the middle of the night? So yeah, so it's something that it just makes so much difference to have that kind of knowledge. So once you're taking care of the lifestyle, once you're taking care of the sleep hygiene, if that's all good and they're still struggling with sleep, then you can start looking at, what are they eating? Are they doing the caffeine at 6 o'clock? Which I made that mistake the other day. There was this wonderful, delicious green tea. It was so good. And I'm like drinking it because it tasted so good. I guess it was up at 3 o'clock. So what are they having late? The second thing would be, then you can start looking at their hormones. What is their progesterone? If it's low, you can think about supplementing with oral, not topical. Oral's the one that's going to impact their sleep. And melatonin, of course, everybody loves. Just want to make sure that you're not giving them super physiologic levels of melatonin. They don't need more than 1 milligram, really. 3 max, and that's really on the high side. The body doesn't know what to do with it. So you want to make sure that that's number 2. And then number 3, if their cortisol, if you're looking at their cortisol numbers, if their cortisol is high, how do we fix that? How do we start getting that back down to where it needs to be? Stress reduction, of course. Do they need the help with, adaptogens or something of that sort? Magnesium. Oh, magnesium is a wonderful supplement all around, as far as sleep is concerned, and so many other things. So those would be the things that I would say initially. If you've done all of those, and they're still struggling, sleep apnea test, of course. What else might there be? Those would probably be the biggest ones. And if you get all of those, baseline, great. That's pretty much going to take care of most of them.
Good job. And alcohol, I would cut that out.
Oh, yeah. Thank you. Thank you. Yes.
And nicotine, I would cut those out.
Yes. That goes all in that lifestyle thing. And a lot of times, this is the type of patient, client, whomever, because they're so stressed during the day, they come home and what's the first thing they do? Get a glass of wine, or 2, or sometimes 3. And that's the other thing we're starting to see as well, that alcohol has a much higher effect on women than we initially thought. So we are not little men. Okay, we are a totally different species. Well, not species. You know what I mean. Okay, so we've got this one. All right, let's go into our next one. So the more is better trap. Okay, so now we've got Jennifer. She's an elite athlete, 49. She's a marathon runner and coach. BMI is 21. So people say, oh, great, resting heart rate 48. So she's in good shape for the most part. But she's coming in complaining of declining performance, persistent fatigue, irregular periods, which is going to go along with perimenopause anyway. But now she's got that tibial stress fracture. Okay. I'm training harder than ever, adding extra miles, but my times are getting slower and I'm gaining body fat. She's just complaining, right? She's been an athlete for 25 years. She also intermittent fasts, skips breakfast, right? Because she's gonna do that fasted cardio, right? And then she's going to CrossFit, and she's training 6 days a week. And her idea is rest is for the week. Okay. As I mentioned, recently diagnosed with a tibial stress fracture, feeling wired and tired, and not recovering. Menstrual cycles are erratic, ranging from 21 to 45 days, or absent for months at a time. So we know from last time she is definitely in perimenopause, right? So what, number one, do you think she fits the criteria for RED-S, the relative energy deficiency in sports? And I didn't give her numbers, so, you can kind of guess yes or no, but by the fact that she's working hard 6 to 7 days, fasting and cardio, and doing CrossFit. I don't know if any of you have ever done CrossFit. Anyway, it's hard. So doing it fasted is tough. So I'm just going to answer this one for you. Yes, she is. Okay. How is the combination of fasting plus perimenopause plus high volume training creating a perfect storm? What do you think?
I don't know. So for one, I have to break it up. So for the fasting, for sure, she just don't have enough uh energy to match, meaning energy caloric intake to match the output.
Mhm.
That'll be fun for sure. Her estrogen, progesterone are on the decline for sure. And then I'm pretty sure with all of that storm is driving up her cortisol. Um,
Mhm.
and then she seems very high strung, high stress just because I'm looking at the one, she's a elite trainer.
Mhm.
And then two, her when she made the comment, rest is for the weak. Mhm. So those are my first few thoughts.
Exactly. Yeah. Yeah.
Overload.
Mhm. Overload. Yeah, she has burnt that body to the ground, essentially. Yeah, absolutely. I mean, look, we just talked about what that declining estrogen and testosterone tends to do to our joints and muscles. What does she got? Tibial and bone, tibial stress fracture. Okay. So, but because she's a marathon runner, is she going to want to stop? No, she's going to keep going. And so she is totally overloading her body. All right. So, what do you think? And I'm going to actually change this. I just said, what's the primary intervention needed regarding her fueling? But also, what about her training? So, fueling, I think, is a pretty simple answer. And as I'm going through this, what would you do with her fueling? What would you tell her?
Looks like she may need maybe more calories, healthy calories, just to sustain her energy output.
Mm-hmm. You were going to say something also? Oh yeah. Okay. Yeah, absolutely. And because for years she has done her cardio fasting, it may be hard for her in the beginning. So maybe tell her start with, a handful of nuts or something before she goes. And then just kind of see how that makes her feel as she's going along. Okay. Absolutely. And so that's the fueling. What would you tell her about her working out? Because this is where she may go along with the fueling. Okay, yeah, I'll add some protein. I'll do some whatever. Well, how would you approach telling her about the workouts? This is like the musician who's on
Yeah,
the
that's gonna be
stage. So,
tough because that's the
mhm,
thing that fuels her. You take that away, she's gonna be mentally
mhm.
stimulated. Yeah.
It's
It's a
definitely a
lot,
tricky
it's a lot
thing.
of workouts. A lot of
Yeah,
workouts.
Plus,
yeah,
that's
yeah.
fueling her endorphins too, so it helps her to feel good in
Right,
one aspect.
right,
So
right. Yeah,
that's
yeah.
gonna be hard.
Mm-hmm. Mm-hmm. So this is the thing where initially, when we're first starting and everything, we want to just let her keep doing what she's doing, you know. But eventually we have to be able to understand how do we make her see what this is doing to her body at this stage in her life. Okay, that's the important thing. It's this stage in her life. It's not necessarily forever, but right now, these are the changes that she's going to need to make if she wants to not continue to decline.
Such a big statement, the stage in our life. It's really important as a provider to think about, we do have different stages in life and we can't do what we did when we were, in the teens or 20s or 30s, 40s. Life is different.
It's different. It's
Right.
different.
Well said.
You remember that picture of me when I was dancing? If I tried to get in that position now, forget it. There's no way.
Whoa.
No way. Right.
About how old were you?
I was in my late teens to early 20s.
Whoa.
Yeah, yeah. So, no, no, I probably wouldn't be able to get off the floor again if I try something like that now. So that's another thing, helping them to get the grace to understand that we can't do everything forever. And at some point we have to make the choice. Is it time to say, okay, maybe I will continue running marathons because I think there was a woman who was like 80 something who just ran one. Maybe I will, but I'm not going to train as hard. Maybe I'll leave CrossFit and do something that's more strengthening for the body. Even yoga. You know, um, yoga can be hard.
Yeah, that's
But
what I
a
was
little bit,
thinking.
it can be hard. So,
Heated power yoga is one of the most intense forms of exercise you can ever do. I
yeah,
do it
yeah.
3 or 4 times a week.
Yeah. And people don't realize that it is tough. You got the CrossFit people, and I'm not joking CrossFit. I'm just saying the people who are in the gym and doing heavy lifting and things of that sort. And they feel that that's the only way you can get strong. Well, darn, it's not true. Your body, using your body weight and connecting with your brain, with your brain and I mean, because that's what yoga is. It's a whole body practice. Same thing with Tai Chi and Qigong. So it's a way of switching how we're thinking about working out and moving that can be all the difference.
It's
Okay.
really true. When I come out of a heated power yoga class, the most thing I'm physically exhausted, tired, and sweaty, but the
Uh-huh.
mental clarity and focus is amazing.
Yes, yes, yes. And so maybe with her, it's just, how do we start flipping what we're doing and how we're doing it to make that difference? Okay. And then our last patient before we get too long, dear to our heart, right? This is now the healthcare provider. She's the ER physician, so she's got that trauma coming in, boom, boom, boom. And years after being a surgical intern, we in our hospital we had this code 1111. So it was 1111 that would come through on your beeper because we had beepers back then. That number would come through and it meant get yourself down to the ER because there's a nasty trauma waiting for you. And to this day, when I see 1111, whether it's on a clock or whatever, it kind of boosts my heart rate just goes up a little bit. So there is that whole ER thing going on. But with her, she's got these aches and she's exhausted. And, she's being told that she has fibromyalgia. Okay. Which, is kind of like a diagnosis of exclusion. If you can't figure anything else out, then maybe it's fibromyalgia. She takes care of everyone else every day. By the time she gets home, she's empty. I ache everywhere, and I think I'm done with medicine. Okay. Um, she's really kind of thinking about that. Estrogen, progesterone levels are erratic, and they correlate with when she has these flare ups in pain. Okay. So, how does that history work as a compound injury when combined with perimenopause? Now, this should be like real simple now. She's working nights. Let's make it even more clear. She's working nights. She's got the ER shift. Oh
Mm-hmm.
no, it says rotating. Yeah, that's even worse. Oh my goodness. She's got rotating shifts, which is even worse. So
Mm-hmm.
she can't even her body. What is this?
Can't recover. It's hard to recover
Yeah,
from the shift work.
right.
Mm-hmm.
It's flipping back and forth. So first she's working nights and then she's working days, and it's
No,
just kind of
that's
flipping
awful.
back and forth. And
That's
her
terrible. That
body,
should be a crime.
yeah, right, right. Oh my goodness. So that's a huge one. Why might her fibromyalgia symptoms actually be a manifestations of the HPA immune dysregulation? Because
Because
we know
that's how
that's
it
happening.
present. It can present as pain,
Mm-hmm. Mm-hmm.
tired, fatigue.
Mm-hmm. And when you're stressed, it messes with you. If you remember back, it's going to mess with your estrogen. It also messes with
Mhm.
your testosterone. Although we didn't really talk about that one yet. But yeah, so it's going to mess with those two, which have a lot to do with how your body perceives pain. Okay. So stress, pain, and not necessarily fibromyalgia. And so again, here, this is kind of like what we were talking about with the other person. How do we reframe self-care as a clinical necessity? This is now her survival rather than a luxury. What do we say to her when she's coming to us? You know,
It's a really difficult question. Honestly, we're having to reframe her whole entire way she thinks about her life. She's just
mm-hmm.
amazing, very amazing, strong, brilliant woman doctor that helps people all the time, but at the expense of helping herself. So we have to say, you know what, you need to put the most important patient there is, which is yourself, because if you're not healthy, you're not strong, you can't take care of anybody. So we kind of have to reframe the picture for her, maybe reprioritize things.
Exactly. Exactly. And it's hard, it's hard, especially because that's why she went into the field. That's why we went into the field. It's to help other people. That's where we get that's our love. That's what we feed our souls with that. But we also have to understand that, just like they say on the airplane, put your oxygen mask on first. You cannot, fill another's cup from an empty well, whatever way you want to use it.
It's a great analogy. The oxygen mask first. That's such a great analogy.
Exactly. You got to do you first. And something that I find helps with them is who struggle with that whole self-care thing is to have them take out their phone and put something in there right then and there, because everything else is in there, all their other appointments and the things that they've got to do, but have them put in, this is going to be my time that I'm going to take care of myself. And whatever that looks like. That's the other thing. A lot of times we think it has to be a bubble bath or whatever. No, it has to be something that brings them joy.
I like that.
Yeah. Okay. All right. So those are our 3 cases, and we do have a few more minutes. I would love if you all would do this for me, just to kind of give feedback. This is our new course. Well, first lesson in our new course here on Med Bio Institute. If you can scan that code and you put in chaos, CHAOS, it's going to ask you 5 quick questions. And if you'll answer those questions for me, I'm going to give you the download of the whole presentation with the answers and everything. I hope you understand that or have seen that the answers that's why it's more a discussion than answers per se, because each person is going to have different ways to approach. The issues are different, and how you approach them and the order that you approach them are all going to be different. So it's really not so much let me learn this protocol, but let me understand what I have to look at and work with first to make the other steps afterwards work better. Okay, does that make sense? Hopefully it does. Okay, I'll give that just another second or so, and then we'll do our last little point, and then I'll open up for any other questions. But thank you so much for being here. You guys were great. I loved it. Okay. And if you're done, just let me know, and actually I can go on.
Just want to say thank you so much for tonight. You did an amazing job. I know it's a small class, but it's kind of like sitting in the kitchen just talking to friends, An amazing session.
Exactly. Well, thank you so much.
I agree. Thank you so much. This was excellent.
Thank you. So 4 little key takeaways. Those are the 4 things, and just remember that we've got to restore them before we optimize them. And like I said, you'll get the whole presentation, and let's stay connected. I would love to do that.
Oh, excellent. Thank you so much.
Thank you again. Have a great night.
And actually, we'll share all the materials. There was a question about that, so.
Oh, okay. So it'll just be email.
Yeah, we'll share everything out. We'll share out the recording, and then we will see you guys on Thursday.
Okay, sounds good.
Bye-bye,
Thank you. Have a good night.
Thank you. Appreciate your time.
Thank you. Thanks. Bye-bye.